Jill and Sam are now going to present the next level, the prospective data, looking forward, not looking backward.
All right, thank you for that introduction, and thank you so much for having us here to speak today. Kim, Riley, and Julie all did a wonderful job, as Ingo mentioned, going through what we can do with retrospective data, and we're gonna give a sense of what we've been able to do so far with our prospective natural history study, and what we can look forward to in the future. So as many of you in this room are aware, CHOP and Penn recently founded ENDD, or a Center for Epilepsy and Neurodevelopmental Disorders. And this center has a goal to accelerate research and therapies for rare neurodevelopmental disorders. And we're focusing on 2 developmental disorders, STXBP1 and SYNGAP1. And there's 2 main arms to ENDD. The first is translational research, which is run by Ben Prosser and Bev Davidson. And we're not going to focus on that today. But we will be focusing on our clinical research arm, which is run by Ingo Helbig, and houses our natural history study. And given the size of the screens, it's probably very difficult to make anything out on the slide, but this is a broad schematic of our natural history study and what we're hoping to accomplish. Our overarching goal is to evaluate 100 children with SYNGAP1, both cross-sectionally initially, which is the phase we're in right now, where we're trying to recruit as many individuals as possible to join our study. And then we're gonna keep following people longitudinally every 6 months. And I'm gonna run through on the next few slides what our study encompasses, and then we'll take you through some initial results. So prior to coming to CHOP to be evaluated by us, we are asking families to complete a number of caregiver surveys. And these are assessing domains of daily functioning, communication, sensory processing, quality of life, adaptive behavior, other behavioral concerns, sleep, seizures, and autism. Then, as many people who have participated already in our study in this room can tell you, you come to CHOP for the day, and it's quite a full day. We have neuro evaluations, developmental pediatricians evaluate all of our patients, PT and OT assessments, developmental testing, and quantitative EEG as well. And then after you leave is when the work starts for us with the data analysis, where we're doing QEEG data analysis, detailed seizure history reconstructions, developmental outcomes, trying to get a sense of genotype-phenotype correlations, and outcome prediction. So just to give you a little taste of what we've learned so far, and just as a reminder, we only launched this study in July, but we have seen so far to date 38 individuals with SYNGAP as of the week before Thanksgiving. Slight female preponderance, 62% female, 38% male. We are 78% white, so we're looking to try to recruit as broad demographics as possible. And then our median age assessment is 6.6 years, but we've seen kids from less than 2 all the way up to 67 years old. I apologize, this slide we just found out today does not display on this computer, but this was a map showing you lovely where all of our patients have come from. But I can tell you, we've seen people from all across the US, and then one individual from Canada as well. Similar to the figure that Riley showed you earlier, here's our variant spectrum of our patients we've evaluated to date. Seems representative of what's been published in the literature as well, mostly protein truncating variants, but we've had 6 individuals with missense variants as well. And most of the participants we've evaluated have been diagnosed either with a panel or on exome sequencing. And now I'm going to turn it over to Sam to talk about some of our initial developmental scale results.
Okay, so I'm not going to talk about any of the parent-reported outcome measures because we still have to analyze all that data, so we're just going to talk about the assessments that were done clinically by the team at CHOP. So one area that we've been looking at is general classification scales. These have mostly been developed for kids with cerebral palsy, but the MAX, Minimax, and CFCS have been used with other patient populations as well. And where this is important is this starts to get at easy ways to describe groups of kids to a rehab audience and to an audience that's looking at who might be a responder to a different intervention, whether it is a rehab intervention or potentially a treatment. So that, just to kind of orient you, 1 means it's the highest level of function, 5 is the lowest level of function. So it kind of matches the data that we've already seen today, where GMFCS, gross motor function, most of the kids are going to be very mobile. Max and mini-max are going to be fine motor function. That's going to be a little bit more in between. And then most of the most common reported issues that we've seen with our kids is going to be with communication. And the CFCS is both expressive and receptive language. It isn't limited by verbal. You're able to use assistive technology to try and rate how someone's able to communicate their basic needs. The Bailey-4 we've been using. So this is a norm reference test for kids from 0 to 42 months old. So we've been using this out of age range for some of our children so that we're really only able to report age equivalence, which is AE, so that we see the general pattern that the kids are basically around an 18-month level, at least based on this test. And this is very standardized, where there's very strict rules of what you're able to do, which sometimes gets challenging, I think, with some of the kids that we're working with. So that one of the things that we're doing with this natural history study is to try and figure out what are the best outcome measures to use for children, so that the Bailey takes about 45 minutes to do, and if we find out that it's pretty much equal to some of the other tests that we've been doing, we might decide in the future as we progress in the study to substitute in a different test or reduce this out of the test, just depending on what's most important and what's most meaningful for families and their caregivers. Okay. Just to give you a little idea of some of the kind of the curves that we're having. So this is not the longitudinal start of the study, this is the cross-sectional, but the gist that I'm seeing is that you're seeing those lines that are saying that kids are progressing as they get older. Generally, I mean, these aren't the same kids being measured more than one time. That's going to be ongoing research for us, so that hopefully we'll be able to come up with our own SYNGAP-specific developmental curves and milestones, so that you can imagine that in the future, if you're able to have a different intervention that might be able to either change the rate of gaining skills or change kind of the ceiling of gaining skills, that would be potentially that 10% difference that Mike was mentioning in one of the other presentations. GMFM, so this is a scale that's specific for kids with cerebral palsy, so that we've been using this with our kids with SYNGAP, and basically 100% is typically developing 5-year-old. So with this, like the mean is about a 65, and that basically, from my experience, is a child who's able to walk by themselves, do the steps with help of a railing, and probably do some basic running and jumping, which is what we've seen in most of the kids that we've seen so far. So with this, one of the things we're going to need to do is see kids over time so we can have our own developmental curves for the GMFM, which is something that we have for our kids with cerebral palsy. So that if you combine the classification scale, say the GMFCS with the GMFM for kids with cerebral palsy, at 18 months, I can say this kid has a GMFCS level 2, and then at the age of 7, this is what I should expect them to do, more or less. That's with data with like hundreds and hundreds of children that have been collected over the years. So it's going to take us some time to be able to get to that level of data, hopefully. Peabody-3, so Peabody-3 is another developmental assessment. We've only been using the fine motor subtest of this just because of all the amount of gross motor testing we're already doing and the language testing that we're doing. So we're doing hand manipulation, eye-hand coordination, and the same pattern that we've seen before is that kids are about a 2-year level of functioning while we're seeing improvements over time. CARS 2, so this is also a classification system. This is for trying to decide kind of almost like risk of autism is the best way that I think about it. And what we're seeing is that, autism is a very complicated diagnosis. This is not a substitute for looking at the DSM-5 criteria, but it's a good way to get kids into categories of whether or not they're minimal to low to no symptoms, mild to moderate, or severe. And most of the kids that we've seen so far have been in that either mild to moderate or severe symptoms. Okay, and we tag back into Jill.
So coming back to biomarker discovery and quantitative EEG, just wanted to go over some very preliminary results, and most of this work has been done by Peter Gaylor, who's a graduate student in Ingo's lab. So this initial preliminary data I'm going to show you includes 38 EEGs across 15 individuals, obtained from ages of 1 to 27 years. And this plot here, I'm showing you the relative delta power in the frontal lobe, so the front part of the brain, across different age groups in both control, so healthy, normal individuals, and children with SYNGAP. And there's a suggestion here that there's some increased frontal delta power in those with SYNGAP. And then here's another preliminary finding looking at, instead of the front of the head, now we're looking at the back of the head and the occipital lobe, looking at the alpha band relative power. And you can see that there is a trend for decreased alpha power posteriorly in those with SYNGAP compared to other healthy controls. So this is definitely a team sport. We want to thank everyone a lot of people have gone into this, not just Sam and I. Want to thank everyone from our center, from ENDD, and then from our CHOP Epilepsy Neurogenetics Initiative. And then definitely want to thank all of you who have come to participate. If anyone in the audience hasn't come see us and wants to, you can just send an email to endd@chop.edu. We would love to see you. We'd love to walk you through what a visit would entail in more detail. And then we also want to thank all of our funders.